I'm going to introduce the speaker for tonight, who is Associate Professor Justin Yeung, who is the Head of Department of Surgery at the Western Health, and he's also a colorectal surgeon, who's going to talk to you tonight.
Useful for series of lectures is kind of turn things around a little bit, so I can just vaguely remember how it was at your stage, okay? And what I really wanted at that stage is, what is it like to be a particular type of doctor, okay? And how did you actually get to that stage? Does that make sense? So hopefully by the end of this evening, I have about 45 minutes, I will inspire you to do some sort of surgery. And hopefully by the end of the lecture series, you might have a better idea what kind of surgery you want to do. Does that sound cool? Yeah? Okay, cool. So, just an overview. I've been to the lecture to know how to tell you guys something. So who am I and what do I do? I'm going to talk a little bit about what is a colorectal surgeon and cover a little bit about what's in the future and what you can do to get ahead at this moment in time when you're a medical student at university. Okay? So who wanted to be a superhero when you grew up? Certainly I want to be a superhero. Yeah, a few. Great, okay. And for me, being a superhero, what was it important? I thought it was important trying to help people, okay? And I thought that by being Batman, I can have lots of equipment and I can help people, okay? And my mum said, no, Asian mum, you can't do that. Yeah. And so that was the end of it, okay? So I became a doctor. Anyway, so what am I? So I'm a colorectal surgeon, but also I work for the university, okay? And hopefully by the end of this lecture, I'll kind of tell you guys what I find really satisfying working for the university, and one of the things is coming to speak to you guys, telling you a little bit about what to avoid and what to take on board. So for those who don't know Melbourne much, this is where we are at the Star. And I work in this little place called St. Albans of Sunshine Hospital. Okay? It's a great place. Okay? You hear some good and bad things about it, but I enjoy working there because I work with a bunch of really, really hard-working people. People who want to work in the outer areas of Melbourne actually do it for a reason. Okay? So that's the first thing, take home message. Okay? And what does that mean? It means that I work with a diverse bunch of people, and I know one of the things we want to improve on is diversity. But more importantly, our patient cohort is immensely diverse, okay, which is fantastic. It means like sometimes in clinic I have 7 or 8 translators in it in the morning because I can't speak the language. But with that though, we have patients who are in great need of care. Okay, so patients who have poor access to facilities, they may have not had basic education about what's important to be healthy. So our patients are usually much more complex. They come with much more complex diseases. I'm a colorectal surgeon, so the thing that I deal with the most is cancer. They come and have the most severe forms of cancer, which isn't fair. If you look at the east side, Thorac, okay, completely different cohort of patients, right? So I enjoy what I do because it's a challenge, all right? And so come to Western and you see a lot of pathology. I'll take a message. So what do you think I do? It's colorectal cut. So I don't like picking on people. What's your advice? What do you think? Yeah, so what does that mean? Cut cancers? Anything else? Sorry, fine. Anything else? I had a phone call just now, literally a few minutes ago. I'm not on call, but people are asking me for advice. Okay, so we also deal with acuity, and a lot of the work that I do is emergency surgery. Okay, and with our cohort patients, they may not be very well, and they come in with an emergency, and you need to have a team of people being able to deal with it. So that's equally a challenge. So I do a lot of emergency work as well. And I thought, well, how best to tell you guys what I do? So I thought I'll give you my timetable for the week, a bit like your timetable, I guess. So Monday, a couple of weeks ago, I go out to Sunbury, fantastic place, where I do lots of day case surgery, endoscopy. and then I rush back to have a research meeting with the university that evening. I do a lot of research. I'll talk a little bit about that later on. That means me coming to Parkville, having a chat with people that decide on curriculums and stuff like that. I'm on call. And what that means, I'm on call not just in the evening, I'm on call during that daytime. So if, say, something comes in and needs me to help out, then that means I have to cancel a lot of these things. So it's a lot of what I do is, when you become a consultant, is be better management of your time. Okay, you need to have time management is very important being a doctor. Okay, there's no point taking 20 hours to clock one patient in because you've got 20 other patients to look after. So time management is essential at your stage. And you can see I get involved with things like teaching and other really interesting stuff. Okay. So what is my kind of day-to-day thing, kind of responsibilities? Where do they lie? So you can divide into kind of 4 different sections. Okay. One is the surgery, which is why you're here. Okay. You want to hear all about the gruesome stuff. Okay. So that's great. I do operating. I do big cases. You'll see a big case later. I'll show you a video. There's a lot of ward work. There's a lot of clinic work. The on-call. Okay. Which is sometimes exciting. Sometimes it isn't. And also, I think it's important is how can we make our hospital better? Okay, and you've probably heard of Footscray Hospital. We've got lots of money. We're going to be building a new hospital, so that's very exciting now for me to be involved in the planning. How do we make sure that as students you get access to patients in the clinic? You've got rooms for yourself to use for teaching. You know, all these things. A hospital person doesn't really think about these things. Yeah, you probably find that when you go in your hospital placements. Oh, there's no room for you guys. Oh, there's no room for you to speak to the patient. Yeah, and that's bad planning. So we need to make it better for you guys. Medical school, so I do lots of teaching, both at Western, but also here centrally, okay, and planning courses. Very important, what you guys want to become as junior doctors, so who guides them? So we're very responsible for making sure that they have a mentor, making sure that we help them with passing certain exams, and we'll be talking about exams in a short while. So there's quite a lot of activity there. And finally, my other hat is making sure that we do research. So some of your MDRP students, I know, that's great. We also have PhD students in the firm. So you can see there's kind of lots of variety, and I like variety. So to be a surgeon, you almost, most surgeons don't like sitting around for many hours. We always have several things going. So that's your personality. That's again something that is positive to pull you towards and push you towards surgery. Okay. So what is colorectal surgery? So we touched upon it. The colleague mentioned some fantastic things. Colorectal cancer surgery is the main thing. We do all benign stuff, hemorrhoids, fissures, lumps and bumps. We also do general surgery, so the more further out you are as your base hospital, then you tend to be doing more general stuff, you know, carpal tunnel, you know, hernias and stuff like that. When you're more centrally based, when you're at the Peter MacCallum, you know, then you do very specialized cancer stuff. So it does depend on where you're based, and it therefore determines what you do in certain ways. And I said emergency surgery can be exciting. Sometimes we have stabbings, car crashes, those kind of things. So it does make me quite fulfilled doing all these different things. So why did I choose colorectal surgery? I think the main reasons being that colorectal cancer, being the main bulk of what I do, is a common killer. It's the second most commonest cause of cancer death. 1 in 13 of us, okay, so it'll be a handful of you, unfortunately, will get colorectal cancer. And the top right-hand graph just illustrates that, you know, if we catch colorectal cancer at an early stage, they have a really long survival, okay? Whereas if you catch them at a later stage, stage 4, less than half will survive a year, okay? So that's quite significant. I know this is some old figures, but you know, that's just to give you the kind of comparisons. And therefore, patients do present to us in different stages. They may present without any symptoms, and that's where screening comes in. Okay? They may present with some symptoms for the GP, but the GP felt maybe it's not very specific. And then to the other extreme, when we're on call, you know, people present with bleeding or obstruction. And again, you know, I find that's really fulfilling, being able to kind of deal with patients at different stages of presentation. Likewise, you know, as a clinician, it's really nice to be involved in a patient's journey. Okay, and there's some specialties like people working in the emergency department, very exciting, doing lots of different things. But the disadvantage, I think, from doing that, personal experience, is that you don't know what happens to the patient once they leave your department. Okay, well, colorectal surgeon, we're involved with, you know, detecting things, colonoscopy. Okay, counseling them, seeing them in the clinic, saying this is what you have, doing the surgery, and then being involved with research. Okay, so lots of things to get involved with. All right, but obviously it wouldn't be a surgical lecture unless I show you some gruesome stuff. So are we okay with that? Okay, cool. So this patient that I'm showing is a patient who has perhaps the most severe forms of colorectal cancer, in that it requires the most extensive amount of surgery. So this patient's going to have an abdominal perineal excision, so it's an APR. So in other words, we're taking out their rectum and anus because they have rectal cancer, but the cancer is also involving the back of her vagina. Okay, so we're going to take a donut of that tissue as well to make sure that she's cancer free. Okay, make sense? Okay, cool. So, a little anatomy. Okay. So you can see that within outwith of the rectum is your pelvis, okay, which limits what we can take away. You have that rectum and anus, and behind you have the coccyx and sacrum, and in front your vagina, okay. And actually you have the pelvic side walls as well. So the actual operation involves coring out that bit of tissue, okay. And this is the position that we operate on. So a patient is lying prone. We do the abdominal bits first before we then go on to the perineal or anal side. Okay. And what we're doing here, my colleague's just kind of making that initial incision around the anal canal. Okay. So vagina sitting to your left, okay. Sacrum, coccyx to your right. Okay. Can you all see at the back? Yeah. And there's lots of tissues, ischial-rectal fossa that we're cutting through. Okay, a lot of fatty tissue. Yeah. The structures that we have to be careful of is that we don't want to go too posteriorly, otherwise we end up going into the pelvic veins that you read about. Okay, and if the pelvic veins bleed, they bleed like hell. Okay, so it's very difficult to control. Okay, this is what we call a lone star retractor. That just kind of separate and pull all the tissue out of the way so that we have a good view of doing that pouring out of the rectum. So we've got two instruments holding on to the anal canal. Okay, you can see by putting some tension, we actually identify where the planes are. Okay, and outside of what we're dissecting is that pelvic wall we talked about on that anatomy slide earlier on. We don't operate that fast, but this is speeding through. All right, now be careful of videos. People always give you the best bits and cut out the bits that don't go well. Okay, so here we're taking out the coccyx so that we can then enter the back of that rectal area. Okay. It's pretty easy surgery, you know, as long as you know where not to go into, okay? You're just pouring out this bit of tissue. Okay, so I'll just speed it along a little bit. Okay, so once we've got in a fair distance, we then kind of pop ourselves into that kind of peritoneum that you kind of hear about and read about when you do anatomy. Okay, so we're just going into the pelvis, and we know we're in because there's some kind of blood-stained tissue coming through, and that's pulled from the original first part of the operation. Okay. We're going through your levators, okay? We'll take you through the pelvic floor. So you remember all that kind of anatomy you have to learn about the pelvic floor and all these different muscle groups, and you think, what's the point of learning them? Well, still, I forget the names anyway. Just as long as you know you're there. I'm just being honest with you, okay? We have lots of toys to play around with. We have this sealing device called a ligature, okay, which helps burn things. So it's fantastic. Okay. And we were just going through that muscle that's kind of fixing that rectum in place. And I'm just going to finish off here. So here we are, just pulling it out, okay? Like obstetrics bringing out the baby, okay? Yeah. So we're taking out sigmoid, rectum, and then we're just taking it off finally where it's connected up to the back vagina, okay? So that whole operation from doing the top bit, freeing stuff out, then putting the patient on their front and doing this bottom bit probably takes about 5 hours, something like that. Okay? And then afterwards, if it's quite a big tissue that we take away, and we sometimes get the plastic surgeons to fill the gap with a flap, an IGAM flap or some kind of malacutaneous flap. Okay, so that takes about 2 or 3 hours as well. So essentially, it's a whole day procedure. Any questions before I go on? No? Okay. That's the specimen. Okay. Okay, all good. Right. So, quickly moving on to research. So, research at Western Health, what I'm getting involved with. So, sorry, yes.
Yes. What's the quality of life like post surgery?
Okay. So let me ask you back a question. Okay. So if you, touch wood, had cancer, okay, meant you had two options. You either have surgery to remove the cancer, so you're cancer free, but you had a stoma and maybe had a wound that might break down and take several months to heal, versus die of cancer in 2 years' time, at your age of 20-something.
Oh no, it's a tough decision.
It is a tough decision, correct?
Tough,
And I think just to show that our patients go through the same decision making, okay? But when it's you're in that situation, and that's the only option. You either go for surgery or you don't. I know what I would choose. If I was 89, I probably won't go for that operation. But if I'm 20-something, God yes. Does that make sense? But we're not forcing ideas on people. We give them the choice. And the important thing is not just choice, but giving them the information that they can understand so that they can make an educated decision what that's right for them. Quite often, as doctors, we don't give people all the information. We just kind of almost tell them what to do. Is that right? Maybe? Sir?
So how long would it take for a patient to recover from surgery?
Yeah. So they're out of hospital in about a week or 10 days. Okay. But they normally take about, if they don't have any other complications and the wound down in the bottom is the one that doesn't heal that often, but if that's healed, they're probably back to normal function about 3 or 4 months. Okay. Again, it's depending on how determined they are. If they go into surgery thinking, I'm gonna do really badly, I hate my life, blah blah blah, then they probably won't as quickly or get back to fairly normality, if that makes sense. Yeah.
Will you still operate on a grade 4, like a very late stage cancer?
So we're talking about if they have evidence of cancer that's spread to other organs. Depends on what organs they are and how extensively spread they are. So when I was at your stage, okay, many years ago, technology allowed us to operate on the liver much or the lungs much, which are the 2 common organs that it goes to. Okay. Nowadays, if they affect half the liver, those who are at the Austin, we do liver resections, or other at Western Health we do, liver resections. Okay. Those at St. Bede's, we do lung resections, okay? But if there's multiple organs with multiple areas affected, then you can't then surgically cure them. Then why put them for an operation if you're not going to cure them? You're going to give them poor quality of life, aren't you? Okay?
I guess I'm also just curious, so in that particular procedure, like
Yeah.
once the patient's recovered,
Yeah.
what kind of functions do they still have? Like how much, once you take the tumor out, how much do you actually put out?
So bowel function, they'll have a bag. That'll be permanent, okay?
Yeah.
The poo will go into the bag, okay? Unfortunately, because they have lots of autonomic nerves that are in the area in question, they make damage, so they may get sexual dysfunction, they may get urinary dysfunction, okay? They may get some pain, chronic pain, if they, because of such a big operation. Okay? But most people do okay. You'd be surprised what people do after this operation. There's some really, it's like our spectrum of patients. You can't generalize. Okay? Some people are going to be really active and lead a normal life as best they can do. There's those who don't. Okay. I've got a lot to go through, so shall we move on? Yeah? Okay. So research. So what research do I get involved with that I find interesting? So the research that I find interesting is things that we can translate to current practice, okay? I have done lots of bench work stuff before, but I'm really interested in how can we quickly get solutions to problems, okay? And some of the solutions may not be disease related. So one of the projects we're doing, we're looking into how better to teach you guys how to stitch. So at the moment, one of my MERP students is doing some online video with diagram enhancements, okay, which is very different from what you get from YouTube. Okay. So hopefully that will be then driven out to available to everyone on the Uni Melbourne campus. Okay. That's what I find quite interesting. Other things that we get involved with, I'm looking into nutritional aspects, preoperative factors, because that's what determines whether a patient does well or not. If they come in, they're obese, they're a smoker, they're cardiac disease, they're bound to have worse outcomes compared to a young, fit 20-year-old who runs all the time. Agreed? So we're trying to work out ways that we can improve on that over a short period of time before they actually have cancer surgery, for example. Okay, so lots of kind of interesting stuff. How do you become a colorectal surgeon? I think that's hopefully what you guys will be asking me. Okay. So it's quite a busy map, but I think you guys at the moment are somewhere at the top of the hill. Up there, yeah? Agreed? Yeah? Okay. And then once you qualify, then you do your intern year, which is a year's worth of internship. Okay. And then you go into decide, well, I want to do kind of surgical aspect. So you go and choose a residency program or an HMO program whereby you're going to get to rotate round every 3 months, different type of surgical allied specialties perhaps. And that's something useful to do because that you need to have that background experience for number one to know this is really what you want to do, but equally to apply to vocational training or what we call SET training. So that's SET, S-E-T, that's surgical education and training. Okay? That's where the problem is. That's where the bottleneck is. Okay? And I have currently 10 non-accredited registrars who want to apply to SET training. Okay? Unfortunately, those were almost the same 10 that applied last year. Okay, who didn't get in. Okay, well, like one of them got in. When you look at the figures in 2018 last year, there were 120 positions in Australia. Right? Not Victoria, not Melbourne. How many people are there in your year of medical school? Someone said 350. Is that in the first year? How many graduates? 350?
330.
330, okay? So if all of you wanted to go and do surgery, which is not true, okay? Other things. But then there's other medical schools, isn't there? Yeah? And there's other cities and other states. So actually the bottleneck is there. Alright? So what you need to do now is to be able to have enough kind of track record, be it teaching, research, whatever, for you to be able to then hit hard and get into set training. Okay? Because you'll probably not be able to do much when you're being a resident. You speak to the residents in your hospital, and they're there at 6 and they finish at 12 or whatever. Ridiculous hours. Okay? And that's just doing work, nothing to do towards the set training applications. Okay? So when do you have the most freest time? It's now, isn't it? You're here. You're doing other stuff. Yeah? Very good. So, and to be a colorectal surgeon, so you finish your set training, you're qualified as a general surgeon, okay? But you're not a colorectal surgeon yet. Okay? And I'll talk to you briefly what you need to do to be a colorectal surgeon. Is this what you want to hear, team? Yeah? Okay. Very good. Stuff, this is what I'm talking about, so there you go. So you complete set, okay? Once you complete set, all right, set is usually 5 years of general surgical training that you go and do different specialties, which is really good, okay? But to complete set, you need to have a couple of things. You need to make sure that you operate well and have done enough to fulfill your logbook requirements. But equally, you need to sit the fellowship exam, which is a combination of written and OSCEs and orals and basically like that. And there's a bit of an art to be able to pass these exams, and not everyone does first go. Okay? But when you do, that's when you get your fracture fellowship of the Royal College of Australasia. Okay? And that's when you then, if you want to be a colorectal surgeon, then you have to go into fellowship training. Okay? Because as your set rotations, you do colorectal surgery, but the level of surgical procedures you get involved with and get to do is only kind of the middle level. Okay, so that APR operation we did, okay, that's only done when you're a fellow. Okay? So fellowship training for many of the specialties, be it upper GI, endocrine, colorectal, usually it's 2 years. All right, and there's different routes. Okay, so there's another bottleneck, unfortunately. To get into fellowship training is quite difficult as well. So because you look at the Colorectal Society in Australia, okay, New Zealand, there's 28 centres, so there's 28 positions for people to train to be a colorectal surgeon. Okay, it's a 2-year program. Okay, but there's a lot of people who don't get on. So what do? Some of them go elsewhere. They go to the UK, they go to the States. There's some positions in Australia that actually aren't linked to the fellowship program, and they do a non-accredited fellowship year, okay, hoping that doing that 1 year will then give them enough on their CV to then be successful the next year. Okay. Well, some of them go down the research route, because looking at generally, when you guys come out of the university and then go through the training program, very few of you will have enough research to bulk up your CV to be able to get into that shortlisted for that training program. And that's why a lot of people decide to do a PhD or a master's or something along their journey. Okay. But you shouldn't be doing it if you don't really are interested in it, if that makes sense. Okay? You do something that you find interesting. So it may not be a research degree that you do, maybe a teaching degree. If you like teaching, yeah, you can do an education degree. If you like business, you can do an MBA. All right. Lots of different options. But I think you guys have to start thinking outside the box to be a little bit clever to make sure that you're sellable or you can get into that. There's more and more competition. Okay, you're going to get people like me from the UK coming to Australia want to get your jobs. Okay, I'm lucky. But you see what I'm trying to say? The competition is going to be great. And when I was at your stage, there was only 100 people, 150 people my year in medical school. Okay, it's a big difference. Right, so when you become a consultant, you think that's great, you drive a nice car, you have lots of money, you're out and eat, yeah? Not as straightforward, but where do you work as a consultant? What are the options, team? Where can I work? St. Bees, Austin, Ballarat. What decides where people go? Sorry? Patients, okay. So maybe your interest, you want to help certain patient groups, agreed? Yeah. Any other reasons, guys?
They'll give you a job.
They'll give you a job, correct. Sometimes it's like that, okay? I think a lot of it's also who you're working with. Okay? It's a bit like friends at school or university, then you tend to hang out with the same type of people. Okay? If you imagine you're working for the rest of your life in one institution that you don't really like working with those people, so it would be a miserable time. That would be my take-home message as well. Okay? But also maybe you want to work in an institution that actually does really good work. Yeah? You don't want to be working in a place whereby the care is terrible necessarily. You may want to. You want to bring up that care. Right? So different people have different reasons to work in different places. So as I said, you might want to be, some consultants come out and they just decide I want to work at the Epworth, okay? All right. Some people say, look, I want to work Central Teaching Hospital or Melbourne, Mac, okay? Or maybe go into, the community hospital, in the further out, okay? But what you probably find most consultants do, they actually work in more than one institution, okay? You notice that they kind of here for half a day and then you don't see them again until the next week, okay? And that's how the system's been set up. They're what we call visiting medical officers. So they have a very small appointment in one hospital, and then they go to another hospital, and they go to another hospital. Okay? So what problem does that lead to patient care, guys? Yes. Who actually does all the work? Registrars, the junior staff actually looking at the patient on a day-to-day basis. Okay? That's good in that they are the same people, but they may lack the expertise to be able to identify when a patient's not very well, or not just right, or there's something different about this patient that we need to do something quickly about, otherwise they'll have a bad outcome. Okay? And that's part of the problem with the system. Okay? So, just so that you need to be aware. We're doing okay with time? Okay, right. You can tell I like kind of comics and stuff like that. So anyway, Star Trek, for those who are not Trekkies, okay? What might kind of, next few slides, really talk a little bit about what's happening to treatment to patients, okay? Why have I shown that slide? Basically because what we're trying to do, okay, is nowadays, what's new is tailoring our treatment to the patient, okay? Rather than put 10 patients through the same treatment program, which may not work for all of them, we're trying to tailor their treatment. And how can we do that? What are we doing? Okay, so we look at screening, okay? Colorectal, we're looking at genetics. So people come in, they have a colon cancer, they're very young. We're looking at whether they have certain mutations, which may firstly affect what type of oncological treatment we give them, but whether they have a genetic predisposition that we need to then screen their relatives with. Okay, so that's pretty, I know it's been around a bit, but that's exciting. We're screening better, so we have better tests to screen for asymptomatic patients to see whether they might have colon cancer. Okay, that's great. A little bit what I'm already doing back at Western is trying to see whether there's anything that we can identify that can improve patient outcomes in the pre-operative setting. So a good example is that patients of the same BMI may not be the same. You can have a very lean, full of good muscle bulk, have the same BMI as someone who's got visceral fat, morbidly obese. Yeah? And their outcomes are going to be different. But at the moment, we're just treating them as the same. Okay? And some of the stuff that people are looking at, is looking at kind of measuring the amount of what we call body composition, or amount of body fat, muscle bulk, using things like CT scans. Does anyone know who Peter Mansfield is? Obviously very famous. Yeah. He's to do imaging, so he actually helped develop the MRI scanner. Okay. And I trained in Nottingham, and this is where in the UK that he was based in Nottingham. He's a tram named after him in Nottingham. Quite sad, but what this MRI scan does, it allows us to better tailor our treatment towards rectal cancers. Okay? If you imagine your rectum, okay, it's like a Swiss roll, okay? And you've got the cancer in the middle, okay? You've got your mesorectum, or the normal healthy tissue around it, okay? And as a surgeon, we're going to take that out, okay? Great, fantastic. However, not all cancers are going to be sitting right in that middle of the Swiss roll, okay? And with the MRI scan, as you know, we can detect whether patients have a bit of locally advanced disease that's involving the side wall. So if we were just to simply take it out, they're going to have residual disease. Okay, so these people, we're going to give them some X-ray therapy, chemotherapy, trying to shrivel that up a little bit, so then the margin becomes clear, and then we do the surgery. Okay? So that's really common practice nowadays, MRI scans. How did he become the Hulk?
Gamma.
Gamma. Why did I mention gamma? PET scans. Heard of PET scans, guys? Positron emission tomography. So that the gamma radiation is released. Okay. So the idea of PET scans is what we call functional scan. Okay. So we give radio-labeled glucose, FDG, to patients, and patient cells that are highly active, so cancer cells in particular, will take up that bit of material and then release a bright light that you can see on the scan. So this patient, not sure whether they got liver metastasis, when you look at a PET scan, it's bright, okay? So there's lots of fancy technology now that allows us to better stage patients, which answers your question earlier. I think someone asked, what happens if they have stage 4 disease? Well, it depends on what type of stage 4, how severe. Okay? We also have cancers that disappear. 20% of our rectal cancers, after giving radiotherapy, chemotherapy, seem to disappear or complete response. So should we be operating on these? Currently we do. Okay? But it comes to a point whereby I think we're working that way. In the next 10 years, we're going to be able to identify some cancers that we know will go away completely, and we won't need to operate. So they won't need to have that awful operation that you just saw, which is not so great quality of life. Okay. There's also kind of fancy kits like robotics, and they're going to get smaller. Okay, so there's only one company that's been dominating our practice, the Da Vinci robot, but Google and other kind of companies are making smaller, more portable, remote operating that we can do. So we can in the future be operating Ballarat in a very complex case with a robot, with the surgeon being in and say, here, yeah, which is fantastic, isn't it? You heard of circulating DNA team? So that's really evidence of cancer cells within the bloodstream. Okay, colorectal cancer cells. And what we do, we take a blood test and test whether they have these cancer cells, and if they do, that determines whether they have some chemotherapy after colorectal cancer. So in the olden days, we would just base it on their histology, what the cancer looks like when we chop it out. Okay, we don't know what's happening in the body, and this is revolutionary. Okay, and Peter Gibbs and his team at the Lehigh are instrumental. This is kind of recent stuff, really exciting. Okay. Again, we're tailoring the therapies to patients. Talked about quality of life, and I think it's another thing that we're trying to look into. Certainly, my team are looking into patient-reported outcome measures, or PROMs, or quality of life measures, to look at how treatment and also how, over time, patients' quality of life changes. And it's something that we don't measure. All we measure is we're taking the cancer out, bye-bye, that's it. We don't actually see how it affects the quality of life. And I think that's another thing that's kind of on the horizon. And finally, in regards to what else is going to be on the horizon, I think it's meant to represent registries, okay? So it's coming. So us getting data on everyone, my health records, whatever, to then be able to see how disease and treatment on the real life platform happens, okay? Because a lot of our experiments are in selectively recruited patients of a particular type. And we don't know in real life how it affects patients with Western health who are overweight or from ethnic backgrounds. Okay, and that's where registry trials and registries are very important. So that's what hospitals are trying to develop. Okay. Just a few final slides. Okay. just my own thoughts about what you need to be thinking about as a student, okay? Surgeon's career, I think when you think about surgeon's career, you need to think about being a doctor. You also need to think about yourself, being an individual, okay? Make the most time in your placement, okay? So it doesn't matter where at work or at St. D's. Be there. I see some students at Western, let me comment on that. Some of them really keen, they do everything, and other people just hang around in the student quarters and play a bit of pool, whatever. That's fine, it's up to them. But, you know, being a student is great because you can go into any operating theatre and those people will be welcoming and tell you things. Okay? And you're a consultant. When I walk into theatre, no one talks to me because they think I know everything. Yeah? That's not true. So use your opportunity. Okay? Explore. Develop skills. What skills? You know, suturing, knot tying. And you're very keen to do that. Laps, catheters, NG tubes. All these things. Very important. And I think it's also important to, once you learn those skills, is be able to teach your colleagues, okay? Help the younger medical students be able to do things and work with your student society. You know, how can your society help? You know, you've got a great society. They develop this lecture series. Tell them what you want. Your local precinct might be doing some skills labs. Tell them what you want to learn. Okay, they're there to help. And I briefly mentioned about what limits doctors from getting to set training. Well, I think certainly looking at CVs of my registrars who don't get into the program, it's all these things. You know, most of them have pretty good references, okay, because they're working 24/7. Okay, but it's what determines whether they get selected is whether they have some background in research, background in teaching. Okay, and it's not just teaching, doing a lecture once a year. They need to show a continued process of that. And I think that's why you guys, you know, should think about that. You need to think about your side of the box, all right? You need to be different. So use your opportunities. MDRP, choose your project well. Speak to people who are doing MDRP projects. They're not all the same. They promise certain things, some people, but it doesn't get delivered, okay? So like TripAdvisor, find out from people what's a good project. Does it give you the research experience? Does it give you opportunities to go to clinic, to see patients, go to theatre? You know, those kind of projects I feel is pretty rewarding. Okay, rather than sitting on the lab and putting things in test tube and don't get much out of it. I don't know. That's my own opinion. Think about surgical electives. Where do you want to go? Right? Because that's really a stepping stone. If you say you go abroad, some people want to go and work in the third world. Okay, and learn some skills. That's fine. We want to go to somewhere famous in the world, pediatric center in Toronto in Canada, because they want to be a pediatrician. That's great. That's where you develop your links. Okay. Intern placement. Think about which institution you want to apply to. Do you get a lot of mentorship? Do you get a lot of experience? All right. And think about the future. If you're thinking about going to the States for your fellowship, do you do your USMLEs now? When you're kind of pretty hot on your topics. Okay. These things you need to think about. All right? Very quickly, you need to be professional. I think that's very important. When you're an intern, aim high, get challenged, take on jobs and responsibilities. Okay, you're there to learn. Okay. Go to chat to doctors. So, you know, you have the best resource. You've got doctors walking around everywhere. Ask them what they feel about working in that place, what they feel about their experiences, how they would do things differently if they were in your position. I can't tell everything to you in the lecture, but I'm just giving you some pointers where I find it be useful. Okay? Be aware of mindfulness. It's not just work, okay? You need to have something outside of work. Family, relationships, I think that's very important. So finally, to wrap up, sorry I've taken a bit of time, okay? To go back to my first few kind of comments, who am I and what I do? What is a colorectal surgeon? What's in the future? What can you do now to get you ahead? So hopefully I've answered those. Questions that I asked myself, did I become who and what I wanted to be? So I think I did become a surgeon. I knew that when I was at your stage, I wanted to do surgery. I wanted to do colorectal surgery. Okay? So I was very kind of I'm very happy that's what I've become. Have I become what I set out to be? Probably not. I didn't set out to do academic work. Okay, and I fell into that almost. But that's fine. You know, you need to be flexible in what you do. Okay, not be fixed. Was being a colorectal surgeon what I expected? Yes and no. I didn't expect technology and advances to be so quick. All right. When I was your stage, we just did things open, did the right hemicolectomies, left hemicolectomies. People with hernias stayed in for 5 days. I thought this is a great life, you know, looking at these patients. So I think patients, we're getting more and more complex patients. Patients are getting more elderly, and they have more complex conditions that we have to be mindful of. Okay, but I think that's good. You know, we need to be challenged. Okay, is there a future still being a colorectal surgeon with all these advances? I think there is. Colorectal conditions are so common, it doesn't matter whether you live in the country or in the city, Asians will always have conditions, people always rely on you for some advice and help. So I think, you know, it's a really rewarding type of thing, especially if you like doing lots of different types of things. So one day I might be doing endoscopy, another day I'll do surgery, another day I'll do research. I like that kind of thing. Okay. What do I wish I had known? Okay. I think it goes back to my initial thing about being a superhero, okay? Maybe I haven't become a superhero, but I do help people. I do get to play around with fancy equipment, okay? But it's not just me doing it, I work as a team. I think that's the important thing to take away. Okay? You can't do everything yourself. Okay.